Let me introduce myself. Good evening. My name is Inass Shaltout, Professor of Internal Medicine and Diabetes, Cairo University, and I'm going to talk about management of people with diabetes in the era of COVID-19 pandemic. The global impact of COVID-19 has been profound, and it is the most serious respiratory virus pandemic since the 1918 H1N1 influenza pandemic. And COVID-19 has now 1.8 million persons and 116,000 deaths confirmed worldwide, and 204 countries reported cases. This is today, April 13, 2020, and the mortality is becoming 6.1%. COVID-19 is a new strain of coronavirus. It is a family of wide range of different strains, including that causing common cold. What is COVID-19? COVID-19 is a single-stranded RNA virus having a shape of crown or coronet. It's an imaginary shape of crown, and 82% with that of human SARS-CoV, which is later called CoV-1, and for this reason it was called SARS-CoV-2. The genomic analysis suggests it evolved from bats in 89% nucleotide similarity with bat SARS. The potential amplifying mammalian host intermediate between bats and humans is unknown. And this is the persistence of coronavirus on different surfaces. It can remain on aluminium for 2 to 8 hours, on surgical gloves 8 hours, steel 48 hours, wood 4 days, glass 4 days, paper 4 to 5 days, and plastic up to 5 days. And it is detected in aerosols up to 3 hours and up to 4 hours on copper, and it can survive for 7 days in low temperature and humid temperature, 5 degrees centigrade, or 20 to 30% humidity. Although it's a very strong infecting virus, it can be effectively inactivated by lipid solvents like ether, ethanol, and chlorine-containing disinfectants. These are the most common symptoms of COVID-19 infection: fever in 87% of cases, dry cough in 67% of cases, fatigue 38%, sputum production 33%, shortness of breath 18%, myalgia, arthralgia 14%, sore throat 13%, headache 13%, chills 11%, nausea or vomiting 5%, and nasal decongestion in 4.8%, diarrhea in 3%, hemoptysis 0.9%, and conjunctival congestion in 0.8%. Initial reported cases were linked in Hunan seafood wholesale market, and there was initial surge of cases in males median age of 55 years. Generally develop signs and symptoms an average of 5 to 6 days after infection. And the respiratory droplets containing the virus may contaminate the surfaces up to 4 days, including screens and smartphones. This is the distribution of COVID-19 and hotspots visualized in red color, and there is cardiovascular manifestations of COVID-19 infection in the form of hypotension, tachycardia, bradycardia, arrhythmia, sometimes sudden cardiac death. COVID-19 can infect the upper and lower respiratory tract, and it has an affinity for cells in the lower respiratory tract and can replicate there. And the radiological evidence of lower respiratory tract lesions shows clinical pneumonia presentation. There are three major patterns for clinical course of infection according to for disease control. Mild cases with upper respiratory tract presenting symptoms in 81%, severe disease with dyspnea and respiratory than 30 per minute, and oxygen concentration less than 93%. This happens in 14% of cases, and rapidly deteriorating chest symptoms and happens 7 to 8 days after infection, needing advanced life support in 5% of cases. This is a type of immunity in COVID-19 infection, whether cellular immunity or humoral immunity. This is some comparison in studies done on SARS and MERS and COVID-19, showing different outcomes on cardiovascular manifestations. In SARS, one study showed hypotension, tachycardia, bradycardia, megaly, and arrhythmia. Pan et al. Showed cardiac arrest with the consequence of death. Lee et al. Showed subclinic diastolic impairment without systolic involvement, and this was reversible. In MERS, acute myocarditis, acute onset heart failure, which recovered mostly. COVID-19, two studies done. One showed myocardial injury, and 4 patients required intensive care hospitalization, which was about 10% of the total cases. And another study on 38 cases showed acute cardiac injury in 7% of cases, shock in 8% of cases, and arrhythmia in 16% of cases, and most patients required intensive care. This is the overall mortality in China, which was 2.3%, and the mortality rate jumped to 6% in hypertensive cases, 7.3% in diabetes, 10.5% in cardiovascular disease patients, and 14.8% above the age of 80. Cases of mortality was higher in cardiovascular disease, showing 10.5%, and it was greater than in patients with chronic respiratory disease, where the percentage of mortality was 6.3%. What about the relation between hypertension, diabetes, and COVID-19? Can we save our patients? A study published in Lancet about COVID-19, actually 3 studies. The first one was done on 32 non-survivors from a group of 52 intensive care unit patients with corona virus COVID-19, and study showed that 22% of non-survivors were having cerebrovascular disease and 22% of the cases were diabetics. Another study done on more than 1,000 cases of confirmed COVID-19, of whom 173 cases had severe disease, and the comorbidities were hypertension in 23%, diabetes 16%, coronary heart disease in 5.8%, and cerebrovascular disease in 2.3%. The third study was on 140 cases were admitted to hospital with COVID-19, and 30% of the cases had hypertension and 12% of the patients had diabetes. There is an interaction between SARS-CoV-2 and the renin-angiotensin-aldosterone system. The coronavirus binds to their target cells through angiotensin-converting enzyme 2, ACE2, which is expressed in epithelial cells of the lungs, of the intestine, of the kidney, and blood cells. ACE2 is linked to diabetes, hypertension, cardiovascular disease, and those are linked to COVID-19 infection. The expression of ACE2 is increased in patients with type 1 and type 2 diabetes, and ACE2 can also be increased by thiazidinones and ibuprofen. That's why anti-inflammatory may be advised to be avoided, but this data is not confirmed yet. Data suggesting that ACE2 expression in diabetes and treatment with ACE inhibitors and ARB increase ACE2 expression. If this hypothesis were to be confirmed, and it is still a hypothesis and not confirmed, then ACE inhibitors and ARBs should be discontinued. We did not find any evidence suggesting that antihypertensive calcium channel blockers increased ACE2 expression. That's why there is an alternative treatment in those patients. Diabetes and COVID-19. Why the association? People with diabetes are having higher risk of infection because of immunity defects. This immunity defect is linked to hyperglycemia, whether acute or chronic hyperglycemia, and there is increased risk of infection because of increased cytokines in diabetic patients. In Chinese survey, 10% of coronavirus patients are diabetics. The scenarios of diabetes management with COVID-19 according to China experience: diabetes mortality 7.3%, all patients mortality 2.3%, non-comorbid conditions mortality 0.9%. In diabetic patients, there was fear and anxiety and tension, which may increase the glucose level or glucose fluctuations. There may be interruption of oral anti-diabetic medications with isolation. COVID-19 causes increased inflammatory cytokines, and using glucocorticoids in treatment of respiratory manifestations may increase hyperglycemia, and also irregular diet, reduced exercise, and gastrointestinal symptoms can cause glucose fluctuations. What are the recommendations of diabetes management during COVID pandemic? This recommendation was done by the Chinese Diabetes Society For mild and moderate non-elderly COVID-19 patients, strict control should be done. For mild and moderate elderly with glucocorticoids, medium control targets are done. For severe critical patients or elderly patients or patients with hypoglycemia or comorbidities or organ dysfunction, low glycemic targets should be reached with a postprandial blood glucose range of 180 to 220 milligram per deciliter. And the treatment, insulin should be the first line of treatment in severe infection and in stable cases. With regular eating pattern, patients can keep on oral treatment. And to avoid metformin in gastrointestinal disturbance and low oxygenation, and DPP-4 inhibitors and SGLT2 inhibitors are not recommended. While in other parts of the world, DPP-4 inhibitors are not contraindicated during COVID-19 infection. Those are the glucose management strategy for different types of diabetes patients with COVID-19 and type 1 diabetes. Insulin pump or basal bolus insulin treatment is the optimal treatment, and the recommended insulin is insulin analog as a first choice, and insulin treatment should be individualized. And for type 2 diabetes, for mild cases with low moderate glucose increase, non-insulin medications can be used. For patients with fever or treated with glucocorticoids, insulin treatment is the first choice, and for critical patients, intravenous insulin is recommended. It is important to monitor cases with glucocorticoids, to monitor the blood glucose level, and to give insulin as a first choice. According to the American Diabetes Association, how coronavirus impact people with diabetes, and the AGA says, are people with diabetes more likely to get COVID-19? And their opinion was no, people with diabetes are not more likely to get COVID-19 than the general population. The problem in people with diabetes is a problem of worse outcome, not a greater chance of contracting the virus. But in China, where most cases have occurred, people with diabetes had higher rate of serious complications and deaths than people without diabetes. Again, the American Diabetes Association said, do people with diabetes have higher chance of experiencing serious complications of COVID-19? With diabetes do face a higher chance of experiencing serious complications with COVID-19, and in general, people with diabetes are more likely to get severe symptoms and complications when infected with the virus. If diabetes is very well managed, the risk of getting sick from COVID-19 is similar to that risk in general population. Is there a difference between type 1 and type 2? In general, we don't have any reason why COVID-19 is different between type 1 or type 2, except for comorbidities which may be present in both types, type 1 or type 2. Also, the age difference in type 2 and comorbidities or complications. People who already have diabetes-related health problems are likely to have worse outcomes if they contract COVID-19 than people who are diabetics but otherwise healthy. And this is the precautions for people with diabetes, which are general precautions for all persons, not for diabetics only. For asymptomatic or mildly symptomatic patients, they recommend to stay home till symptoms improve. SARS-CoV testing is recommended for mild increase in symptoms during home isolation. Remote care via telephone or via video conferences required. For highly symptomatic patients or progressive symptoms, should be evaluated by a mobile testing unit, ambulatory office locations. In SARS-CoV-2, testing to be made available in patients or outpatients with significant symptoms to evaluate whether these patients require hospital admission or not, and the extent of community spread and treatment. Those also are recommendations by the American Diabetes Association and Diabetes UK for people with diabetes. People living with compromised immune system need to take care. Diabetics need to take special care, and infection raises the blood glucose. How should people with diabetes and their families prepare themselves? These general recommendations should be applied, like frequent hand washing like any other person, personal protection, sanitation of devices, phones and laptops with alcohol, minimize unnecessary going out, travel or gathering. And these are some specific measures for people with diabetes. They should prepare for sick days measures, to make SMBG more frequently, to make sure of supplies like medications, like vitamins, rubbing alcohol and soap, and supplies of glucose test strip and ketone strips, and to use the ketone strips if the blood glucose is more than 240, and if they find any acetone in the urine, they should consult the doctor and start taking free water intake. When to contact your doctor for diabetes medications, for medications for cold, flu, and infection, for management of urine ketone if appeared, and for advice about the required medication change if any symptom of COVID-19 happens. And to take home message, diabetes and hypertension should be strictly controlled as preventive action. Thank you.